feel your breath upon my neck, a soft caress as cold as death. I didn't know you well back then. I blame it on luck and fate. Your blood like wine, I want it in. Oh darling, get me drunk and make me feel it's not my fault, I'm not to blame. These ain't my sins, I broke my chains. There's more to do and I still want to live.
I feel your breath upon my neck, a soft caress as cold as death.
Cold as
I feel your heart beat in my soul. Our futures bound, our bodies know. Your blood like wine, I want it in. Oh darling, get me drunk, invite me. It's not my fault, I'm not to blame. These ain't my sins, I broke my chains. There's more to do if I can only leave. I can't go yet, don't let me die. I'll never stop until I'm done. But just tonight, maybe I'll rest in peace. I feel your breath upon my neck, a soft caress as cold as death. I hear your heart beat in my soul. Our endings bound, our bodies know. I can't go yet,
don't let me die.
I want to live.
My only one. There's more to do if we can only live. The clock won't stop and this is what we get.
Alrighty, folks, jumping right into chapter 11. I know my screen. Oh, no. Chapter 11. Wrong button. Sorry, folks. So we're going to go into stress and disease. We'll go over the historical background and general concepts. We'll also see the concepts of stress, homeostasis, and allostasis, and the stress response. However, we are not getting into the stress, illness, and coping aspects. So, again, I know our pages do not correlate 100% because mine is a wonky PDF. However, we'll stop at like page, I guess, 337, or for me, it's going to be page 1087. So we'll jump right into it. To observe the obvious modern society is full of stress. As a culture, Westerners are champions of work ethic, a Protestant philosophy originated in the 16th century that views idleness as taboo. Wow, and therein lies all of our current issues. Stressful experiences include daily hassles, major life events, loss of loved ones, life-threatening illness, loss of job, social isolation, early life social deprivation, abuse, trauma, work-related stress, work-life balance, low economic status, and many other events. For example, the pressure to remain in contact despite illness, travel, vacation, and other events that used to provide socially acceptable temporary absences is now customary in the American and indeed global culture. When added to other well-identified stressors, such as financial problems, the individual may suffer and develop symptoms that reflect that so-called stress-related disorder. When thinking about stress, one must consider the factors producing a perception of stress, which begin with the brain perceives a stimulus as stressful, and then, in turn, promote adaptational and survival-related physiologic responses. However, when the psychological perception of environmental demand exceed the adaptive capacity of the individual to cope, stress may lead to negative affected and health-related disease states. Another way to think about stress involves the short or long-term consequences of today. Today, most researchers consider acute stress to be immunoenhancing, protective, whereas chronic unremitting stress is thought to be immunosuppressive or destructive. A variety of adverse life circumstances affect the pool of circulating leukocytes, involves transcription with increased expression of genes that promote inflammation, and decreased expression of genes that promote antiviral responses. Chronic inflammation contributes to many diseases and drives contemporary morbidity and mortality. Historical background and general concepts. Walter Buchanan used the term stress to encompass both physiologic and psychologic ideas as early as 1914. He applied the engineering concept of stress and strain in a physiologic context and believed that emotional stimuli also were capable of causing stress. In 1946, Hans Selye popularized these same findings, viewing stress as a biologic phenomenon. Originally, Selye inadvertently discovered the biologic syndrome of stress while he was attempting to discover a new sex hormone by, injecting crude ovarian extracts into rats. He repeatedly found that three structural changes occurred: enlargement of the cortex of the adrenal gland, atrophy in the thymus gland and other lymphoid structures, and the development of bleeding ulcers in the stomach and duodenal lining. Selye soon discovered that these manifestations were not specific to injecting ovarian extracts, but also occurred after he exposed the rats to other noxious stimuli, such as cold, surgical injury, and restraint. He called these stimuli stressors. Selye concluded that this triad or syndrome of manifestations represented a nonspecific response to noxious stimuli, naming it the General Adaptation Syndrome, or GAS. He identified the three following successful stages of GAS: the alarming stage, or reaction, in which the central nervous system, the CNS, is aroused by the body's defenses and are mobilized via the fight or flight. The stage of resistance or adaptation, during which the mobilization contributes to fight or flight. The stage of exhaustion, where continuous stress causes the progressive breakdown of compensatory mechanisms, acquired adaptations, and homeostasis. The exhaustion marks the onset of certain diseases. So we got our limbic system, the brainstem, including locus coeruleus, that releases norepinephrine; our sympathetic nervous system, which is our adrenal medulla, which releases epinephrine. That limbic system also, I guess, goes to the brain's region receiving sensory information, which gives a paraventricular nucleus of the hypothalamus to release CRH, which then, I guess, releases into the sympathetic nervous system. That also releases epinephrine. So initially, one becomes alarmed by a stress that activates the hypothalamus and sympathetic nervous system. The resistance or adaptation phase begins with the actions of the hormone cortisol, norepinephrine, and epinephrine. Exhaustion, also known as allostatic overload, discussed later, occurs if stress continues and adaptation is not successful, ultimately causing impairment of the immune response, heart failure, kidney failure, leading to death. Oh boy. So there is a large stress response. Let's see if we can scroll in on this. Boop. So if our stress or stressor affects our central nervous system via the hypothalamus, a corticotropin-releasing hormone, or CRH, is released. And three things will happen. That same stressor can bypass our central nervous system, though, and go straight to the sympathetic nervous system, which will release norepinephrine and epinephrine. But if it does go through our central nervous system via the hypothalamus and releasing that corticotropin-releasing hormone, or CRH, it also will release into the sympathetic nervous system, releasing norepinephrine and epinephrine. It can also, however, have an effect on our posterior pituitary gland and the anterior pituitary gland. So we'll swing off onto that right side first. So if it affects the posterior pituitary gland, we will have an increase in ADH, or vasopressin, which also increases our water retention. At the same time, it'll affect our anterior pituitary gland, which increases our ACTH, which then goes to the adrenal cortex, which increases our cortisol. That increase in cortisol will increase our blood pressure and cardiac output. It decreases the luteinizing hormones, so estradiol and testosterone, and it will increase blood levels of amino acids. This increase in cortisol will also increase our lipolysis in our extremities, causes atrophy in the lymphoid tissue, and increases the lipogenesis in the face and trunk. That atrophy of the lymphoid tissue will then cause an anti-inflammatory or pro-inflammatory, and it can also cause an immunosuppression or enhanced humoral immunity, all due to the increase in cortisol when stress affects the anterior pituitary gland. Now, when that same stress yet again affects our sympathetic nervous system, whether it is through the stress alone or through the corticotropin-releasing hormone, or CRH, our sympathetic nervous system has two responses, once again, the norepinephrine and epinephrine. So if it affects our norepinephrine, it has, I guess, four major reactions here. There is a neuropeptide Y that norepinephrine releases, which causes that vasoconstriction, vascular growth, and angiogenic factor. At the same time, that norepinephrine will increase our blood pressure, increase our pupil dilation, and there is a piloerection, or goosebumps, and actually there are two more that I'm not reading properly. So really norepinephrine does 1, 2, 3, 4, 5, 6 things. So Norepinephrine will have a piloerection, or goosebumps, an increase in arterial smooth muscle contraction, an increase in pupil dilation, an increase in our sweat gland action in our armpits and palm, an increase in blood pressure, and a neuropeptide Y, which releases that vasoconstriction, vascular growth factor, and angiogenic factor. And one last time, that sympathetic nervous system from the corticotropin release from stress or through the central nervous system releases epinephrine. Epinephrine does, let's take a quick count here. 1, 2, 3, 4, 5. It has 5 effects. It'll cause a bronchodilation. There will be an increase in lipolysis, or destruction of our fat cells, which then increases circulating free fatty acids. Our epinephrine also increases force and rate of cardiac contraction, which increases our cardiac output. It also has an effect on our pancreas, decreasing insulin and increasing glucogen. With that decrease in insulin, however, there is a decrease in glucose uptake in skeletal muscle and adipose, whereas that increased glucagon causes increased gluconeogenesis, which increases blood glucose. It also affects our liver, which decreases our glycogen synthesis and increases glycogenolysis, which also causes an increase in gluconeogenesis and increased blood glucose. So stress has quite the effect in our lives. No surprise then why stress is bad. So from a physiologic perspective, what is emerging across the discipline involved? Molecular biology, immunology, neurology, endocrinology, and behavioral science is a more holistic and complex model that involves biochemical relationships of the CNS autonomic nervous system, the hypothalamic-pituitary-adrenal HPA axis, the immune system that causes the stress response identified in Salile. And that is coming up. Here we have stress that affects our hypothalamus via our CRH. Our anterior pituitary gland then releases ACTH that comes from the adrenal glands to the kidneys, where the cortisol is released, which causes a metabolic effect that can again cause a decrease in stress. However, that cortisol, I'm not sure why these are negative effects on the, I guess once the cortisol is released from the kidneys, they negatively affect the pituitary gland, but positively affect the metabolic effects. The hypothalamus-pituitary-adrenal axis, the response to stress begins in the brain. The hypothalamus is the control center in the brain for many hormones, including corticotropin-releasing hormone and adrenocorticotropic hormone. Sure. The concept of stress, homeostasis, and allostasis. Salai believed that stressors cause a general or non-specific response. However, research in the past 50 years has shown the remarkable sensitivity of the central nervous system and endocrine system to psychologic influences. Emotion is included as a psychologic factor that modulates social stress. Thus, although Salile identification of the GAS is regarded as tremendously important and the cornerstone of stress research, the idea that stress is a purely psychological response is vastly oversimplified. In the mid-1950s, studies showed that activation of the adrenal cortex occurred in humans in response to psychological stressors. In monkeys with conditional emotional responses and in humans subject to a very stressful interview technique, in the early 1960s, researchers found that plasma cortisol levels increased in groups of subjects exposed to war movies and decreased while they viewed Disney nature films. Mason later demonstrated that the initiation of the GS depended on the psychological factors surrounding the stressor. He also viewed the various factors, such as degrees of discomfort and unpleasantness, or the suddenness of the stress, could account for the presence or absence of psychological stress responses. Although the term stress was used by many disciplines, and with numerous disagreements over its definition in recent years, stress was defined as a transactional or interactional concept. Transactionally, stress is viewed as a state of affairs arising when a person relates to, interacts, or transacts with situations in certain ways. People are not disturbed by situations per se, but by the way they appraise and react to situations. In general, a person experiences stress when a demand exceeds a person's coping abilities, resulting in reactions such as disturbances of cognition, emotion, and behavior that adversely affects well-being. Moreover, psychological stressors can elicit reactive or anticipatory stress responses. The reactive response is a physiologic response derived from psychological stressors. For example, the stress of an examination may produce an increased heart rate and dry mouth in the unprepared student. The anticipatory response occurs when physiologic responses develop in anticipation of disruption of the optimal steady state, also known as homeostasis. These anticipatory responses can be generated either by species-specific innate programs, such as reacting to the presence of predators and unfamiliar situations, or by experience-dependent memory programs. Created by conditioning, anticipatory responses are learned responses under fine control by regions located in the brain regions most frequently associated with learning and memory and include the hippocampus, amygdala, and prefrontal cortex. In order for these regions to elicit a stress response, a paraventricular nucleus, PVN, of the hypothalamus must be stimulated. The brain structures interact with the PVN through intermediate neurons, some of which are primarily used for a reactive response. In a conditioned response or conditional response, one learns that a specific stimuli, object, or situation context are associated with danger, and as such, anticipation of subsequent encounters with the stimulus produces a physiologic stress response. For example, a child abused by a parent may experience a psychological stress response in anticipation of further abuse when the parent enters the room. Under some circumstances, these memory programs may become so strong that psychological disorders, such as phobias, develop. In a similar fashion, some persons develop post-traumatic stress disorder in response to the memory, as opposed to the anticipation of traumatic events. PTSD is characterized by flashback memories, sleep disturbances, depression, and other symptoms. These symptoms have the potential to greatly compromise normal activities, such as employment, personal relationships, and quality of life. Today, evidence implicates stress as a precipitating factor across a range of diseases and health conditions. The term allostasis, as opposed to homeostasis, is currently used in stress research as a better way to understand how stress influences the development of disease. Unlike having a set point or physiologic equilibrium in the style homeostasis view of psychological stress systems, the allostasis view proposes the physiologic systems are dynamic and capable of changing set points after exposure to stress. This change in physiologic set point, chronic stress-induced elevation in cortisol secretion, may be the culprit underlying pathophysiologic conditions. Allostatic load is the individualized cumulative effects of stressors that exist in people's lives and influence their psychologic response or physiologic response. Allostatic load may be a result from a vulnerable physiologic genetic makeup, lifestyle including damaging health behaviors, daily stressful encounters and extraordinary events such as disasters. Over time, this load exacts a toll on people's bodies, the wear and tear, because the brain is a key player in deciding what is stressful. It is influential in determining when they feel toxic allostatic overload. Under conditions of allostatic overload, the parasympathetic system may decrease its restraint of the sympathetic system, resulting in increased or prolonged inflammatory responses. Furthermore, in response to acute and chronic stress, some regions of the brain, the hippocampus, the amygdala, and prefrontal cortex, may respond by undergoing structural remodeling, which can alter behavioral and physiologic responses, such as cognitive impairment or depression. The adult brain and the developing brain possesses structural and functional plasticity in response to stress, including neuronal replacement, dendritic remodeling, and synapse turnover. Many intra- and intercellular mediators and processes are involved in changing the brain during stress and recovery from stress experiences. Examples of molecules that are necessary or permissive for brain remodeling include brain-derived neurotrophic factor, or BDNF, tissue plasminogen activator, TPA, corticotropin-releasing hormone, CRH, the secreted protein, lipocalin-2, and endocannabinoids, or ECBs. Stress causes an imbalance in neural circuitry that serves cognition, decision-making, and anxiety and mood that can disrupt behavioral states. The imbalance can then affect systemic physiology through neuroendocrine, autonomic, immune, and metabolic mediators. Key mediators and biomarkers of allostatic overload, exaggerated pathophysiologic response to stress, include the glucocorticoid cortisol, catecholamines released from the sympathetic nervous system activation, and pro-inflammatory cytokines. A prevalent example is sleep deprivation resulting from excessive stress. Sleep deprivation has significant damaging effects, including elevated evening cortisol level, elevated insulin and blood glucose levels, increased blood pressure, reduced parasympathetic activity, increased levels of pro-inflammatory cytokines, and increased concentrations of the gut. Hormone ghrelin, which stimulates the appetite. Altogether, these physiologic alterations induced by the cumulative effects of insomnia can lead to the increased caloric intake, depressed mood, cognitive problems, and a host of other potential health issues. So the environmental stressors, work, home, neighborhood, any kind of major life events, trauma, and abuse, that perceived stress that such as a threat, helplessness, or vigilance, can cause a behavioral response such as fight or flight, but can also then affect our diet, smoking, drinking, and exercises. That also create a physiologic response, but that perceived stress can also be individual differences, genes, development, experiments. That can also all trigger a physiologic response in our allostasis and adaptation and our allostatic load of what we can handle. As studies point increasingly to the important role that stress plays in certain disease processes, research has begun to focus on the mechanism and interactions among social, psychologic, biologic, and behavioral risk factors responsible for these mind-body interactions. Molecular biologists, immunologists, neurologists, clinicians, and behavioral scientists are now exploring the role of the other half of the mind-body dualistic model, that is, the mind. What is emerging is a more holistic and complex model of health and disease state. This model involves the biochemical relationship of the central and autonomic nervous system, the endocrine system, and their relationship to stress-elicited coping behaviors that can modify the integrity of the immune system. Discoveries of these complex links have led to the creation of the field of psychoneuroimmunology. So what is psychoneuroimmunologic mediators of stress? The PNI is the study of how the consciousness, or psycho, the brain and spinal cord, neuro, and the body's defense against infection and abnormal cell division, immunologic, interact. PNI assumes that all immune-mediated diseases result from interrelationships among psychologic, emotional, genetic, and behavioral factors with the neurologic, endocrine, and immune system. The immune system is integrated with other psychologic processes and is sensitive to changes in CNS and endocrine functioning that accompany psychologic states. Stressors, such as infection, noise, decreased oxygen supply, pain, malnutrition, heat, cold, trauma, prolonged exertion, radiation, responses to life events, including anxiety, depression, anger, fear, loss, and excitement, obesity, old age, drugs, disease, surgery, and medical treatment can elicit the stress response through the action of nervous and endocrine systems. The field of PNI has generated a large body of research, some of which has led to strenuous scientific debate. For example, mouse models suggest a strong link between stress and breast cancer progression, yet this effect is not consistently found in humans, especially with respect to the causal role of personality in cancer and mortality and morbidity. Current understanding in the PNI field is that hormones released by stress influence many metabolic systems and corresponding psychologic events. Furthermore, data now suggest that psychosocial stressors or interventions modulate the immune system to impact health outcomes. Studies support the link between psychosocial stressors and health outcomes for infectious disease and wound healing. A meta-analysis of 10 studies conducted among persons living in England found that any level of psychological stress is associated with increased mortality and increased risk of death from cardiovascular disease, external causes, and cancers, albeit only a higher level of stress. 68,000 persons were used in this study, and personal factors, such as age, smoking, and alcohol use, were adjusted accordingly. Investigators studied workplace stressors and health outcomes. Using meta-analysis of 228 studies, they found that job insecurities increased the odds of reporting poor health by about 50%. High job demands raise the odds of having a diagnosed illness by 35%, and long work hours increased mortality by almost 20%. Work-related stress can cause both behavior and psychosocial problems. The WHO report focuses on the stress and health outcomes from work, summarizes psychosocial hazards that may affect both psychologic and physical health directly or indirectly through the experience of stress and risk for work-related stress. So the stress response. The perception of stress initiates a series of events in the central and peripheral nervous system. In the brain, stress elicits an anticipatory response that activates the limbic system, the brain area responsible for motivation, emotion, and cognition. The limbic system also indirectly elicits both an endocrine stress response by stimulating neural pathways responsible for receiving sensory information and the release of norepinephrine from the locus cerebrale. Norepinephrine releases promotes arousal, increased vigilance, and anxiety, as well as other protective emotional responses. The fast-acting sympathetic adrenal medullary system in the periphery releases the catecholamines norepinephrine and epinephrine, and the slower-acting HPA system culminates in the secretion of cortisol. The activation of these two stress systems redirects adaptive energy to the CNS and peripheral body sites to cope with stress. The sympathetic nervous system. Catecholamines. Stress activates the sympathetic nervous system to stimulate the release of catecholamines, both epinephrine and norepinephrine, from the adrenal medulla into the bloodstream and nerve endings that innervate peripheral organs and tissues. The adrenal medulla is an extension of that sympathetic nervous system because preganglionic fibers from the splanchnic nerve terminate in the medulla to innervate chromaffin cells that produce catecholamines. These adrenergic effector molecules have multiple effects on gene expression and cellular function in the nervous, endocrine, cardiovascular, gastrointestinal, respiratory, reproductive, and immune system. Each adrenergic system regulates cellular function through distinct receptors, alpha-1, alpha-2, betas 1, 2, and 3, coupled to G protein-mediated signal transduction pathways. For example, the acute fight-or-flight response increases the heart rate by activating beta-1 adrenergic receptors in the heart muscle. Blood from superficial tissues is redistributed to long muscles by activating vascular alpha-1 and beta-2 adrenergic receptors. Respiratory rate is increased by activating bronchial alpha-1 and beta-2 adrenergic receptors. Energy is mobilized by activating beta-2 and beta-3 adrenergic receptors in adipose tissue and the liver, and immune cells, such as natural killer cells, are mobilized into circulation by activating beta-2 adrenergic receptors on leukocytes. The physiologic effects of the catecholamines on organs and tissues are summarized in Table 1.2. So there's some physiologic effects of catecholamines. So we'll look those over at a later time. Epinephrine is rapidly transported to and acts on several organs, but it is metabolized quickly, making it short-acting. Metabolically, epinephrine causes transient hyperglycemia, or high blood glucose levels, decreases glucose uptake in the muscles and other organs, and decreases insulin release from the pancreas. This is accomplished by activating enzymes whose actions promote glucose formation or gluconeogenesis and glycogen breakdown, glucogenolysis, in the liver while inhibiting glycogen formation. This prevents glucose from being taken up by the peripheral tissue and preserves it from the CNS. Further, very little adrenal norepinephrine reaches distal tissue. Thus, the effects caused by norepinephrine during the stress response are primarily elicited from the SNS. Epinephrine has a greater influence on the cardiac action and is the principal catecholamine involved in the metabolic regulation. Epinephrine enhances myocardial contractility, an inotropic effect, increases the heart rate, a chronotropic effect, and increases venous return to the heart, all of which increases cardiac output and blood pressure. Epinephrine dilates blood vessels of skeletal muscle, allowing for greater oxygenation. Epinephrine in the liver and skeletal muscles is rapidly metabolized and dilates blood vessels, supplying skeletal muscles, allowing for more oxygenation. Epinephrine also mobilizes free fatty acids and cholesterol by stimulating lipolysis, freeing triglycerides and fatty acids from fat stores, and by inhibiting the degradation of circulating cholesterol to bile acids. The metabolic actions of epinephrine aid the metabolic action of cortisol, which are similar. Table 11.2 summarizes the actions of two subclasses of adrenergic receptors. Epinephrine binds to and activates both alpha and beta adrenergic receptors. Norepinephrine at physiologic concentrations binds primarily to alpha adrenergic receptors. So just a small little table here. Alpha 1, increased glycogenolysis, your smooth muscle contraction, so blood vessels and genitourinary tract. Alpha 2, a smooth muscle relaxation, gastrointestinal tract, smooth muscle contraction, some vascular beds. The inhibition of lipolysis, renin release, platelet aggregation, and insulin secretion. Your beta 1, stimulation of lipolysis, myocardial contraction. So an increased rate, increased force of contraction. And finally, beta 2, the increased hepatic gluconeogenesis, increased hepatic glycogenolysis, increased muscle glycogenolysis, increased release of insulin, glucagon, renin, your smooth muscle relaxation in the bronchi, blood vessels, genitourinary tract, and gastrointestinal tract. So, what does that mean? Well, our catecholamines can modify the number of cells of the immune system circulating in the blood. Injection of epinephrine into healthy human subjects is associated with a transient increase of the number of lymphocytes, our T cells and natural killer cells, in the peripheral blood. Specifically, the level of T cytotoxic and especially natural killer cells increase, whereas little change occurs in the levels of B lymphocytes. Qualitatively, lymphocyte responsiveness of T and B lymphocytes is reduced. A lymphocyte responsiveness of the T and B lymphocytes is reduced. Okay. Similar quantitative and qualitative changes are found 5 to 6 minutes after exposure to a psychologic or physical stressor. However, the effects of an acute elevation of catecholamine levels on the alteration of lymphocyte function are short-lived, lasting only about 2 hours. Catecholamines are also increase pro-inflammatory cytokine production. For example, causing increased heart rate and blood pressure, glucocorticoids are known to inhibit this pro-inflammatory production. However, inhibition depends on the dose and cell of tissue type. More simply, glucocorticoids can also promote inflammation depending on dose and cell type. The possibility that chronic and dysfunctional HPA axis stimulation, as may occur during chronic inflammation, increases inflammation in the brain and other tissue, may contribute to other diseases, including osteoporosis, metabolic diseases, diabetes and obesity, and cardiovascular disease. Additionally, these interactions are nonlinear and very complex. So then we have our parasympathetic system. The parasympathetic system balances the sympathetic nervous system and thus it influences adaptation and maladaptation to stressful events. The parasympathetic system also has an anti-inflammatory effect and opposes the sympathetic catecholamine response, for example, by slowing the heart rate. Researchers evaluate the relative balance on the parasympathetic and sympathetic nervous systems using a technique known as heart rate variability, the measurement of R-wave variables from the heartbeat to heartbeat. So, the neuroendocrine regulation. The hypothalamic-pituitary-adrenal system. In sequence, the PVN of the hypothalamus secretes corticotropin-releasing hormone, known as CRH, which binds to specific receptors on anterior pituitary cells that, in turn, produce adrenocorticotropic hormone, or ACTH. So, our anterior pituitary gland produces ACTH, whereas our hypothalamus secretes corticotropin-releasing hormone, or CRH. But our corticotropin-releasing hormone attaches to the anterior pituitary gland, and that's why our anterior pituitary gland creates adrenocorticotropic hormone. Okay, just making that clear. So our adrenocorticotropic hormone is then transported through the blood to the adrenal glands located on top of the kidneys. After binding to the specific receptors on the adrenal glands, glucocorticoid hormones are released. Cortisol, or hydrocortisone, is a synthetically produced but chemically identical version of cortisol, initiates a series of metabolic changes. And for that, they want us to take a look at glucocorticoids cortisol. So they can initiate a series of metabolic changes. However, these hormones overall are thought to enhance immunity during acute stress and suppress immunity during chronic stress because the prolonged exposure and increased concentration. Cortisol also sends a negative feedback signal to the pituitary and hypothalamus to terminate the HPA stress response. So once cortisol reaches all tissues, including the brain, easily penetrates cell membranes and reacts with numerous intracellular glucocorticoid receptors. Because they spare almost no tissue or organ and influence a large proportion of the human genome, they exert significant diverse biologic actions. So, what does glucocorticoids or cortisol? Cortisol circulates in the plasma, both protein-bound and free. The main plasma-binding protein is called transcortin, or corticosteroid-binding globulin. The unbound, or free, fraction is only about 8% of the total plasma cortisol and is biologically active. Cortisol mobilizes substances needed for cellular metabolism. One of the primary effects of cortisol is the stimulation of gluconeogenesis, or the formation of glucose from non-carbohydrate sources, such as amino acids and free fatty acids in the liver. In addition, cortisol enhances the elevation of blood glucose levels promoted by other hormones, such as epinephrine, glucagon, and growth hormone. This action by cortisol is said to be permissive for the action of other hormones. Cortisol also inhibits the uptake and oxidation of glucose by many body cells. The overall action of cortisol increases blood glucose concentration, thereby enabling the body to combat the stressor. The physiologic effects of cortisol are summarized. Cortisol also affects protein metabolism. It has an anabolic effect, that is, it increases the rate of synthesis of proteins and ribonucleic acid in the liver. The anabolic effect of cortisol, however, is countered by its catabolic effect on protein stores in other tissues. Protein Catabolism acts to increase levels of circulating amino acids, and chronic exposure to excess cortisol can severely deplete protein stores in muscle, bone, connective tissue, and skin. Further, cortisol acts to reduce protein synthesis in non-hepatic tissues, a loss for which dietary protein cannot compensate. Some evidence suggests that cortisol depresses transport of amino acids into muscle cells, while enhancing their uptake into the liver. Finally, cortisol promotes gastric secretions in the stomach and intestines, potentially causing gastric ulcers. This could account for the gastrointestinal ulceration observed by Celisle. In contrast, norepinephrine reduces gastric secretions. Chronic stress induces effects of glucocorticoids. Chronic secretions of glucocorticoids, along with catecholamines and the immune system, contribute to the development of the metabolic syndrome and the pathogenesis of obesity. Elevated secretion of cortisol, norepinephrine, epinephrine, and interleukin 6 promotes insulin release and decreases levels of growth and sex hormones. Over time, visceral fat increases accompanied by the loss of muscle mass, sarcopenia, and bone mass, osteoporosis. The increase in adipose tissue is accompanied by the secretion of interleukin 6 and other cytokines. As a result, a low-grade systemic inflammatory state emerges that induces insulin resistance and the onset of type 2 diabetes, tumor growth, atherosclerosis, and neurodegeneration. Epidemiologic evidence suggests that prenatal stress, or elevations of levels of glucocorticoids, may increase the subsequent risk of disease in offspring. One study reported that high maternal cortisol concentrations during pregnancy was associated with low birth weight. This cortisol-induced low birth weight increases the offspring's risk of disease in later life. For example, obesity, cardiovascular conditions such as hypertension, and behavioral disorders attributed to the altered brain structure. Thus, abnormal glucocorticoid elevation in utero dramatically affects human pathophysiology and consequently longevity. The inhibitor effects of chronic glucocorticoid secretion on the growth axis are caused in part by elevated CRH secretion, which increases somatostat, the inhibitor of growth hormone, from the pituitary. Evidence linking the role of the HPA system to growth is found in studies showing that children who experienced abuse may have decreased levels of growth hormone and short stature, which is reversed when removed from the abusive stressful environment, and in children with Cushing's syndrome, where chronic exposure glucocorticoid leads to arrested growth. Not sure why any of that is on. Sorry. There we go. No more pop-ups. We'll clear that out. The brain is a target of glucocorticoids and neurotransmitters that alters physiologic, behavioral, cognitive, and immune functions. When exposed to stress or chronic stress, specific brain regions that have glucocorticoid, catecholamine, and excitatory amino acid receptors may undergo dendritic retraction or expansion, cell death, or inhibition of neurogenesis to alter the brain function. Glucocorticoids are involved in stressing circadian regulation and produce actions through the GC receptor, or GR. The GC receptor, or GR, can function as a nuclear transcription factor. Just like the nuclear genome, the mitochondria contain a small genome and the mitochondrial DNA that encodes 13 polypeptides. Recent work has found that in the brain and other systems, GR is translocated from the cytosol to the mitochondria, and that stress and corticosteroids have a direct influence on that mitochondrial DNA, transcription, and mitochondrial physiology. Investigators also found that both acute and chronic stress and GC were linked with changes in function of brain mitochondria. The hippocampus has GR that supports the HPA negative feedback system. Activation of hippocampal GRs by moderate stress also may lead to temporary hippocampal dendritic shrinkage and loss of spines. However, chronic stress may lead to cell death and inhibit neurogenesis. The loss of hippocampal neurons compromises the HPA negative feedback system and promotes the chronic increase in glucocorticoid secretion. This elevated prolonged stress-induced increase of glucocorticoid secretion This elevated prolonged stress-induced increases to glucocorticoids is linked to cognitive defects or deficits and major depression. Furthermore, chronic stress-induced elevations to glucocorticoids may be a risk factor for Alzheimer's disease. Middle-aged women exposed to heightened stress are at increased risk of developing Alzheimer's disease. An animal study showed that stress and glucocorticoid secretions impaired memory and increased tau kinases and hyperphosphorylated tau in the hippocampus and prefrontal cortex. This study provides insight into how the cumulative effects of stress and glucocorticoids exposure over time may progress to Alzheimer's disease through the onset of tau, which mediates the pathogenic actions of amyloid beta. Another brain region influenced by stress is the amygdala, a major site linked to fear and anxiety. Here, chronic stress expands the dendritic fields and the synthesis of CRH neurons. The increase in amygdala CRH neurons is associated with increased fear and autonomic and HPA functioning found in anxiety disorder, such as post-traumatic stress disorder. The prefrontal cortex modulates higher order cognitive function, such as in abstract thinking, executive decision-making processing, and goal-directed behavior. Exposure to chronic stress causes dendritic shrinkage in the medial prefrontal cortex, which may lead to cognitive rigidity or inflexible thinking. However, another region, the orbitofrontal cortex, shows neurons with an expanded dendritic field that may lead to increased fear vigilance. These alterations in the prefrontal cortex disrupt the balance between the fear-generating amygdala and cognitive control or coping with stress. People exposed to high levels of stress have high levels of HPA hormones and catecholamines, impairments in working memory, and the ability to switch to flexible goal-directed behavior of relevance to mental disorder. Stress may exacerbate the onset of schizophrenia. In addition, stress may facilitate the conversion from euthymia to bipolar disorder. In summary, the stress induces alterations in the brain associated with emotional and cognitive disorders. May develop because of an inability of the brain to readily induce synaptic changes that promote recovery and resilience. Effective clinical treatment may be unlocking these inflexible neuron functions and brain circuits and returning the brain to a functional state capable of generating adaptive cognitive and behavioral programs. So, are glucocorticoids, stress, and immune system? Glucocorticoids or cortisol secretion during stress exerts beneficial effects by inhibiting initial inflammatory effects. For example, vasodilation and increased capillary permeability. Cortisol also promotes resolution and repair. These actions are mainly accomplished by facilitating the effects of GR, namely the transcription of genetic material through DNA binding within leukocytes. Because GR is so widely expressed, glucocorticoids influence virtually all immune cells. However, whether cortisol-induced effects are adaptive or destructive may depend on the intensity, type, and duration of the stressor, the tissue involved, and the subsequent concentration and length of cortisol exposure. Finally, glucocorticoids are shown to induce T-cell apoptosis. Cortisol acts to suppress the activity of Th1 cells, which leads to a decrease in innate immunity and the pro-inflammatory response. Cortisol also stimulates the activity of Th2 cells, which increases the adaptive immunity and the anti-inflammatory response. Epinephrine and norepinephrine have similar effect, a decrease in Th1 activity and an increase in Th2 activity. Initially, immune responses are regulated by the cells of innate immunity, called antigen-presenting cells, or APCs, such as monocytes, macrophages, dendritic cells, and other phagocytic cells, and by Th1 and Th2 lymphocytes, cells involved in the adaptive immunity. These cells secrete chemical messengers called cytokines that regulate innate and adaptive immune responses. Cytokines such as the interferons, interleukins, and tumor necrosis factor that stimulate or inhibit various components of the immune system. Antigen-presenting cells also release cytokines that induce T cells to differentiate into Th1 cells. The Th1 cells and APC cytokines work together to stimulate the activity of cytotoxic T cells, natural killer cells, and activated macrophages, the major component of innate immunity. These cytokines also stimulate the synthesis of nitric oxide and other inflammatory mediators that increase chronic delayed type inflammatory response. Because of this effect, the cytokines are sometimes referred to as pro-inflammatory cytokines. The cytokines secreted by the Th2 cells act to inhibit Th1 cells and can promote adaptive immunity by stimulating the growth and activation of mast cells and eosinophils, as well as the differentiation of B-cell immunoglobulins. Thus, cytokines are sometimes referred to as anti-inflammatory cytokines. Moreover, cytokines can act synergistically, antagonistically, or reciprocally. However, the roles of cytokines are highly complex, and much remains unknown. Regardless, the decrease in Th1 activity and the increase in Th2 activity are sometimes called a Th1 to Th2 shift. Individuals experiencing this Th1 to Th2 shift are more likely to experience allergic responses, infections, and temporarily worsening of autoimmune conditions, such as arthritis. The preceding description of the effects of stress hormone on the Th1-Th2 balance may not be accurate for certain local responses, that is, the release of catecholamines, epinephrine and norepinephrine, can cause certain epithelial cells of the lung to release cytokines that promote recruitment of leukocytes, potentially enhancing inflammation and worsening lung function. This paradoxical stress-induced potentiation of inflammation in the lungs may explain why acute respiratory distress syndrome often develops in individuals with major infections associated profound activity of stress response. For years, stress hormones, especially glucocorticoids, cortisol, have been used therapeutically as powerful anti-inflammatory immunosuppressive agents. The synthetic forms of glucocorticoid hormones, exogenous types of anti-inflammatory glucocorticoids administered for the pharmaceutical reaction, are poorly metabolized when compared to the endogenous glucocorticoids, leading to a longer half-life and no circadian rhythm for these compounds. Moreover, these synthetic compounds bind to different targets, so each has a unique effect. Therapeutic levels of glucocorticoids inhibit the accumulation of leukocytes at the site of inflammation and inhibit the release of substances involved in the inflammatory response. So the kinins, plasminogen activating factor, prostaglandins, and histamine from the leukocytes. Glucocorticoids inhibit fibroblast proliferation and function at the site of the inflammatory response. This inhibition accounts for the poor wound healing, increased susceptibility to infection, and decreased inflammatory response that often are noted in individuals with chronic glucocorticoid excess. Paradoxically, elevated levels of glucocorticoids and catecholamines, epinephrine and norepinephrine, both endogenous and exogenously administered, may decrease innate immunity and increase autoimmune response. These effects, which can accentuate inflammation in general and potentially increase neuronal death in stroke victims, may explain the seemingly contradictory stress response of immunosuppression and the increased risk of infection because of that decreased innate immunity with a heightened antibody response and autoimmune disease, which is an increased adaptive immunity. A perioperative risk factor for cancer recurrence is psychologic distress. Beginning with the cancer diagnosis and following surgical and adjuvant treatment, when individuals experience stress, anxiety, and depression, psychologic stress was reported to down-regulate cellular immune factors, including natural killer and cytotoxic T lymphocytes activity, macrophage motility, and phagocytosis. Stress hormones, catecholamines, opioids, and glucocorticoids were relatedly shown in animal experiments to causally promote metastatic progression. Importantly, from animal experiments, a single exposure to stress or stress hormone during a critical period of tumor progression could increase cancer mortality. Surgery itself profoundly suppressed cell-mediated immunity. Surgery and associated neuroendocrine and paracrine responses increased secretion of cortisol, leading to immune suppression and decrease in the number of function of natural killer Th1 and CTL cells. These responses begin before surgery, are increased following surgery, and dissipate during the first few postoperative days or weeks. Immunosuppression during the perioperative period can increase long-term cancer recurrence rates. Interesting. So immunosuppression during the peri-op period can increase long-term cancer recurrence. Unfortunate. So the corticotropin-releasing hormone, or CRH, influences the immune system indirectly by the activation of cortisol and catecholamines. The corticotropin-releasing hormone is secreted by the hypothalamus and also peripherally at inflammatory sites, called the peripheral immune corticotropin-releasing hormone. The peripheral or immune CRH is pro-inflammatory, causing an increase in vasodilation and vascular permeability. Therefore, it appears that mast cells are the target of peripheral CRH. Mast cells release histamine, a well-known mediator or acute inflammation and allergic reaction. Recent evidence suggests that immune cells have histamine receptors and that histamine may have an effect similar to that of catecholamines. This finding suggests that histamine induces acute inflammation and allergic reaction while suppressing Th1 activity, decreasing innate immunity, and promoting Th2 activity, increasing adaptive immunity. A number of stress factors initiating CRH production, including high levels of interleukin-1 and interleukin-6, increases CRH secretion, facilitates cortisol secretion, which in turn inhibits further cytokine release by macrophages and monocytes. The observation that interleukin-1 can elicit changes in the nervous and endocrine system by stimulating CRH production in the hypothalamus is part of a growing body of evidence, demonstrating immune-induced regulation of the CNS. The release of an immune-inflammatory mediators, interleukin-6, tumor necrosis factor alpha, and interferon is triggered by a bacterial or viral infection, cancer, and tissue injury that in turn initiates a stress response through the HPA pathway, enhances systemic production of these cytokines. Also induces other CNS and behavioral changes during the acute phase of an infectious episode, acting either directly or in a distant systemic endocrine way, or indirectly through mediated or neuropeptides. These effects include pyrogenesis or fever, induction of a slow wave sleep, and anorexia, which together are adaptive responses to infection and possible cancer. Slow wave sleep is associated with enhanced release of growth hormone and a reduction in levels of cortisol, which is beneficial for tissue repair and enhanced immune response. In summary, stress can activate an excessive immune response, and through cortisol and catecholamines, suppress the Th1 response and cause a Th1 to Th2 shift. Locally, stress can exert pro-inflammatory or anti-inflammatory effects depending on the chemicals that are released in the local environment and the way the cells of the local environment respond to those chemicals. Moreover, different types of stressors may have variable effects on the immune response. Thus, systemic response to stress may cause a decrease in innate immunity and an enhancement in adaptive immunity, whereas local responses to the stress under certain conditions may induce pro-inflammatory activities that influence the onset and the cause of infectious, autoimmune, inflammatory, allergic, and neoplastic disease. So that leads us to other hormones. The immune system is integrated with other psychological responses or processes and is sensitive to changes in CNS and endocrine functioning, such as those accompanying psychologic states. For example, neuropeptide Y. The sympathetic neurotransmitter and growth factor for many cells is a stress mediator implicated in the atherosclerosis and tissue remodeling. Other hormones that influence the stress response are listed in Table 11.4. Neuropeptides and hormones have a significant effect on the immune response. This effect on immune functioning depends on the type of factor secreted, with some factors enhancing activity, some suppressing activity, and some both enhancing and suppressing activity, depending on the concentration and length of exposure, the target cell, and the specific immune function studied. So, endorphins, pituitary and hypothalamus can activate endorphins, but the hemorrhage increases level to inhibit blood pressure. What? Right. So, for instance, the hormone, the endorphin, comes from the pituitary and hypothalamus, activates the endorphin receptor on the peripheral sensory nerves, leading to a pain relief or analgesia. Hemorrhage increases levels to inhibit blood pressure or delay compensatory changes that would increase blood pressure. Growth hormone from the anterior pituitary gland affect proteins, lipids, carbs, counter affects the insulin involved in tissue repair, may have a factor in the immune system, levels increased after a variety of stressful stimuli, increased levels associated with psychologic stimuli, prolonged stress. Prolactin, which comes from the anterior pituitary gland and numerous extra pituitary tissue sites, increase in response to many stressful stimuli, require more intense stimuli than those leading to increase in catecholamine and cortisol. Oxytocin comes from the hypothalamus that promotes bonding and social attachment. In animals with reduced hypothalamic-pituitary-adrenal activation levels and reduced anxiety, testosterone or Leydig cells and testes, they are characteristics of libido. Levels decrease after stressful stimuli. They decrease by psychologic stimuli. They have a marked reduced in individuals with respiratory failure, and decreased levels occur during aging. Estrogen works in concert with oxytocin, exerting a calming effect during stressful situations. Melatonin is a pineal gland, and that increases during stress. Somatostatin, produced by sensory nerve terminals, and are released from lymphoid cells and the hypothalamus. The natural killers function in immunoglobulin synthesis and decrease by some. Vasoactive intestinal peptide found in neurons. They increase during stress, and the nerves are located both by primary and secondary lymphoid tissues. The calcitonin-generated peptide found in the spinal cord, but also near dendritic cells in the skin and are in the primary and secondary lymphoid tissues. Help modulate immune function and enhance acute inflammatory response. Neuropeptide Y comes from the lymphatic tissues with norepinephrine, and that is a lymphocyte have receptors and thus may modulate their function. Several lines of evidence suggest a neurotransmitter and neurohormone during stress response. So stress-induced regional vasoconstriction. And substance P, also a neuropeptide, classified as tachykinin, found in the brain and secondary lymph nodes or lymphoid tissues, increase in the response to stress. A pro-inflammatory activity induces release of histamine from mast cells during stress response, cause smooth muscle contraction, and increase antibody production. Sure. Lots of hormones. I hope they get explained a little better than that table. Hormones of the female reproductive system. The HPA exist. Wow. We're going to start that over. Hormones of the female reproductive system. The HPA axis exerts powerful multi-level effects on the female reproductive system. Stress generally inhibits the female reproductive system, primarily through the HPA axis. CRH suppression and hypothalamic gonadotropin-releasing hormone, secretions and CRH stimulation of beta-endorphin release, cortisol inhibition secretion and luteinizing hormone, estradiol, progesterone, and possibly testosterone. Cortisol-induced target tissue resistance by estradiol. The locus ceruleus norepinephrine system provides positive input to the reproductive system, which is frequently altered by the stress-activated HPA axis. Sexual stimulation and GnRH neuron activation, however, may cause a gonadal axis to the resistance to suppression by the HPA axis. Presents potential pathologic effects of central and peripheral CRH in women. Estrogen stimulates the HPA axis and HPA responsiveness is greater in women than in men. Estrogen directly stimulates the CRH gene promoter and the central NE system, which may explain the effects of estradiol fluctuations on adult women's slight hypercortisolism, increases in affective anxiety and eating disorder, mood cycles, and vulnerability to autoimmune and inflammatory disease. Estradiol down-regulates glucocorticoid receptor binding in the anterior pituitary, hypothalamus, and hippocampus, which tends to increase HPA activity by interfering with glucocorticoid negative feedback, whereas progesterone opposes these effects, thus alterations in estradiol levels during normal menses. Perimenopause and menopause modify regulatory feedback loop and adaptations over time develop as a new equilibrium is established in the relationship. Over time, these changes increase the incidence of mood alterations, eating disorders, anxiety, depression, weight alterations, and inflammatory and immune disorders. Endorphins and enkephalins. Endorphins and enkephalins, endogenous opiates, are released into the blood as part of the response to stressful stimuli. These proteins found in the brain have pain-relieving capabilities. Stressful stimuli include traumatic injury and an acute, intense stress situation, such as first-time parachute jumping. In inflamed tissue, immune cell-derived endorphins activate endorphin receptors on the peripheral sensory nerves, leading to pain relief or analgesia. Hemorrhage increases beta endorphin levels, which inhibit blood pressure. It increases or delays compensatory changes that increase blood pressure. Thus, endogenous opiates modulate blood pressure and stability, and neuroendocrine and cytokine responses to blood loss. In conditions or activities when endogenous opiates activity increases, people not only experience insensitivity to pain, but also report increased feelings of excitement, positive well-being, or euphoria. In addition, cells of the immune system synthesize and release opioids when lymphoid cells are activated. T and B lymphocytes and mononuclear phagocytes cells have receptors for opioids. Endorphins may play a role in the excitement and exhilaration produced by dancing, contact sports, and combat. Little direct evidence, however, links the endorphin system to most of these activities. Prolactin is released from the anterior pituitary gland as well as numerous extrapituitary tissue sites. It is necessary for lactation and breast development. Prolactin receptors are present in many different tissues, including the liver, kidneys, intestines, and adrenals. Prolactin is also produced by lymphoid cells. Prolactin is necessary for lactation and breast development. Plasma prolactin levels also increase after exposure to a variety of stressful stimuli, including gastroscopy, proctoscopy, pelvic exam, and surgery. After taking examinations and after receiving various sexual stimuli, for example, stimulation of the nipple or areola in women, unlike growth hormone, prolactin levels show little change after exercise. However, similar to growth hormone, prolactin secretion appears to require more intense stimuli than those leading to increases in catecholamine and cortisol levels. Immune cells also are influenced by prolactin. Prolactin acts as a second messenger for interleukin-2 and has a positive influence on B-cell activation and differentiation. Several classes of lymphocyte have receptors for prolactin, suggesting a direct effect on prolactin on immune function. Oxytocin, a peptide hormone and neurotransmitter produced in the hypothalamus, is well known to be secreted by the posterior pituitary in females to induce parturition and lactation. In the brain, oxytocin acts on brain circuits, including the amygdala, HPA, and sympathetic nervous system, to modulate or buffer fear and anxiety and attenuate the HPA stress response. Animal studies further indicate that oxytocin stimulates prosocial behavior, such as maternal and parental care and mother-infant bonding. In humans, oxytocin facilitates interpersonal gaze, social support, maternal care, and when secreted during orgasm in both sexes, the prosocial hormone may promote bonding and social attachment. Some but not all studies further suggest oxytocin may be a role in promoting trust. In summary, oxytocin is increasingly recognized as a prosocial hormone that strengthens the social relationship, social support, and protection, and also attenuates psychosocial stressful events. Testosterone, a hormone secreted by Leydig cells, regulate male secondary sex characteristics and libido. Testosterone levels decrease after stressful stimuli. This decrease in testosterone levels occur after stimuli such as either an anesthetic administration, surgery, marathon running, and mountain climbing. The mechanism causing decreased levels of testosterone is thought to be exerted by cortisol and beta endorphins. Psychologic stimuli also lead to the decrease in testosterone levels. Men engaged in rigorous combat training and those engaged in the first several weeks of officer candidate school experienced significant drops in testosterone levels. However, other data have shown that the psychological stress associated with some types of competition increases both testosterone and cortisol levels, especially in athletes older than 45. Moreover, individuals with acute illness such as respiratory failure, burns, and congestive heart failure show a marked reduction in plasma testosterone. The direct immunologic effects of sex hormones contribute to the sexual dimorphism seen in the incidence of autoimmune disease and the greater susceptibility to sepsis and mortality in males following injury. Estrogens generally are associated with a depression of T-cell dependent immune function and an enhancement of B-cell functions, and androgens suppress both T and B-cell responses. In injury, however, males produce greater amounts of pro-inflammatory cytokines, a profile that is associated with poor outcome. Additionally, androgens appear to induce a greater degree of immune cell apoptosis following injury, a mechanism that may elicit a greater immunosuppression in injured males versus females. Alright, so that is it for Chapter 11, Stress and Disease. I think we're going to cut another break here, and we'll continue with our last chapter of infections.